Okay, self-keep. Okay. Excellent. Just one moment.
Okay.
Mhm. Wait for my cue for the door to shut. All right, so let's get started. We have quite a panel today. It's entitled Addressing Maternal Health and Gender-Based Violence in Times of Crisis. My name is Sandeep Pathal. I'm the Senior Program Associate for the Maternal Health Initiative here at the Woodrow Wilson Center. And today's event is brought to you as part of our Advancing Dialogue on Maternal Health series. And through that series, we look at critical and neglected maternal health issues. And this series is generously supported by the United Nations Population Fund and the Maternal Health Task Force. Women's empowerment and women's rights, as I know many of you come to our events, are themes that we talk about quite a bit. And in that context, we'll be talking about gender-based violence today. The Swiss Embassy has provided support for one of our speakers today as part of an exhibition opening on people in conflict that's happening immediately after this panel. So as we conclude, I will remind you of the wine and cheese that awaits you 2 floors downstairs. As many of you know, here at the Wilson Center, we do have art exhibitions, but we also are the formal memorial to our 28th president. And we bring the worlds of policy, practice, and academia together. We were voted the top think tank to watch in the U.S. and one of the world's top 10. So thank you for joining us and helping us with those rankings. So speaking of watching, I did want to mention that today's event is being webcasted live. So what that means for those of you here in the room is that when we do get to the discussion, I'd ask that you use a mic so those tuning in can hear you. And my colleagues will be around with those mics. Please introduce yourself and affiliation. I also wanted to mention that today's Twitter handle is MH Dialogue. If you need Wi-Fi and aren't already hooked up, the password is on the wall. It is changed regularly, so if you have been here and you're having a hard time getting on, perhaps reload the username and try again. I do now want to direct your attention to our speakers. And for those of you who do come to our events, you know that we do try to vary them up, but generally we have 3 speakers. That is not the case today. And that is because this is such an important and neglected topic. And there's so many different angles to it. Today we're going to be talking about epidemics. We're going to be talking about natural disasters. We're going to be talking about conflict. And so we would be remiss if we didn't have the number of speakers that we have today to touch upon all those different aspects when we think about addressing maternal health and gender-based violence. So we're going to start off with Ugo Daniels, who's the Chief of Humanitarian Response at UNFPA. And she's going to talk a bit about how UNFPA works in areas that are experiencing crisis. So thank you.
Good afternoon, everyone. Thank you, Sandeep. It's such a pleasure to be here, and I'm seeing some really old friends that I haven't seen for quite a while. Thank you so much for being here physically as well as being on through the webcast. It's a great opportunity for me to be on a panel with such distinguished speakers, and also seeing the panel outside for previous distinguished speakers, so no pressure at all. But I always just love opportunities to speak about the work that UNFPA is doing. Of course, we do it with partners and through partners, but UNFPA's role in ensuring that sexual reproductive health and addressing gender-based violence remains a priority, whatever type of disaster there is. So how do I? Oh, I just click anything?
Yes, there we go.
Okay, great. So just by way as an overview, and apologies for those of you who have heard me speak before, because I'm a bit of a broken record on this. But I say it all the time to my colleagues about how our world is becoming increasingly humanitarian. We have seen a significant increase in with regard to conflicts. And since 2008, 111 countries have become less peaceful and have either partially or fully fallen into conflict. And we have 140 million women and girls of reproductive age and about 17 million pregnant women in 11 of the most unpeaceful countries in the world. And what does that mean for their sexual reproductive health and rights, as well as protecting them from gender-based violence? Similarly, with natural disasters, they're also on the increase. And it's a staggering number, 75% of the total population in the world are living in areas that have experienced at least one natural disaster. And then when we look at communicable diseases, we know that in the least developed countries in the world, that this is the #1 cause of death and illnesses, and that women are a predominant number, make up a predominant number of these deaths or morbidities. With regard to displacement and forced migration, as a consequence of either conflict or natural disaster, last year we had the highest number of internally displaced people or refugees worldwide, and 80% of these are women and girls. So what the reality is that we are increasingly living in a world that is unstable, that is fragile, that increases vulnerabilities, that increases risk, and that puts the people that we most want to reach in even greater difficulty. And for UNFPA, with a health as well as a protection mandate, we see ourselves as, having a very clear and particular role that we address in these situations. I also feel it's really important to point out that apart from the increase in conflicts and natural disasters, we're also seeing that they are now of much longer duration, and they are much more varied, as we see particularly now with Ebola. And what this means is that as a crisis becomes more protracted and people are displaced for a longer time, there are other issues that we're also dealing with, apart from what we typically deal with in the acute phase at the beginning of a disaster. Okay, so just so you know that I have the actual cred to be up here and speaking,
Yes.
I've done one slide, rather busy, but just to show what UNFPA has done this past year up to last week, because I know data came in this morning, but I'd already sent my presentation and I couldn't update it. But Across these, we have 33, UNFPA has identified 33 priority high-risk countries, including the countries that are currently responding to what we call the level 3 large-scale disasters in South Sudan, Iraq, Syria, and Central African Republic, as well as the countries affected by Ebola. And across these countries, we have served almost 150,000 women, providing them reproductive health services. We have, in support of that, and has been reaching out to communities, and we've reached over 1 million people in this regard. A key role for UNFPA during emergencies is provision of what we call emergency reproductive health kits, not just for UNFPA, not just for our partners, but for all NGOs and partners responding during emergencies. It says 75,000 kits, which sounds like maybe 75,000 really cute bags, but you need to realize that it's important to realize that some of these kits are 35 boxes that will enable you basically set up an emergency maternity ward if need be. And one kit typically serves a population between 100,000 and 300,000. And of course, like any many development and humanitarian actors do, we have done a significant amount of training, particularly focused on health workers. So that's my cred. So what I'm going to be talking about is based on certainly not just the experience of this year, but this year has really, what we faced this year has really led to a need for us to change the way, well, don't let me say change, has really led to for us to evolve or revolutionize the way we respond in emergencies, because the situation we're in right now is unprecedented. The challenges that we're faced with simultaneously are unprecedented and have been going on for a really much longer than we've been used to. Okay, so if I start off with protection, particularly with regard to gender-based violence, a signature intervention for UNFPA is provision of hygiene kits. Also, but we prefer to call them dignity kits, because these kits ensure, certainly, yes, a woman's hygiene, but her dignity in a crisis situation. And that's with particular, and I'm very proud of the fact, I have to admit, this is from the Philippines. I used to be UNFPA's representative in the Philippines. And this is an example from one of the kits given out during Typhoon Haiyan. And we had learned from the women that one of their greatest needs was for underwear. Rarely are they, they're provided with soap and toothpaste, et cetera, but rarely are they provided with underwear, and that they feel unable to move. They won't leave where they are, whether it's to go and get food, to get health services, if they don't have underwear. So the underwear and the cloth at the back, called a malong, and there are 1,001 uses that they have for the malong. I'm sure for those of you who've been in Asia, you've seen the dance they do for all of us tourists, where they show the 101 ways you can tie a malong. But what's most important for a malong is, in the absence of everything, a woman can actually use a malong to have a shower. She can use a malong and change what she's wearing without exposing her body. Another thing that was particularly important were the whistles. And it's not rocket science why a whistle is important from a protection perspective, as well as the flashlights. We've added solar-powered radios to these because, well, not the solar-powered bit, but because that's obvious in the disaster, there may not be electricity, but the radios, because we're now seeing how important it is to be able to communicate with people who are affected during emergencies. And so this is, it looks really simple, but this is what women said they needed. And another piece I want to point out is, it kind of looks like a pot. It looks like a Le Creuset pot on the right next to the bucket, but it's actually a little potty. And what the women do at night is they put a little water in it, and that's what they use at night rather than having to go to a latrine that is, at one end of a camp, not well lit, not segregated between for women and men. And so they can use the potty and just, throw it out in the morning. And of course, lots of sanitary pads, particularly for women who have given birth. So those are maternity pads. So this has been a really key intervention with regard to protection, sanitation, but it's also really important as an entry, the term we use is entry point, to attract them so that we can engage them and begin to talk to them about how they can protect themselves during emergencies and basic information that they'll need to take care of themselves during pregnancy and during childbirth. And we've gone to great effort to ensure that this is tailored to the specific context that they're in. Now, these pictures are self-evident. One is from South Sudan, one is from Syria. It's about providing reproductive health services. But the point I want to make, and I think the underlying point throughout my presentation, is the importance of integration. We can no longer just provide emergency life-saving services. It's very important to do that. It's very important to ensure that immediately a woman or a girl needs these services, it's available. But what we find now that disasters are becoming more protracted is if the woman or the girl survives, the first week or 2 weeks of the disaster, the next thing that she's contending with is trafficking or forced marriage or a teenage pregnancy or female genital mutilation. And therefore, we can't just do our classic humanitarian interventions. And we had done a survey and had found out that in 81% of the time in those priority countries, the programming that we do during the emergency is actually the entry point for what is done post-recovery and as you transition into development. So right now, we're actually talking about a continuum of programming rather than the classic humanitarian and development programming, because the reality is women and girls don't experience this in compartments. They experience it, it's experienced throughout the period of their displacement. And so just as an example, in the Syrian response, for which we have, I must acknowledge the support that we've received from the US government, and they've particularly supported this clinic where we're really proud we've not had a maternal death there throughout the emergency. But typically what happens is a woman comes in and you put this woman normally on pills, right? It's the easiest and fastest thing that you can give to them. But you're not, particularly for women that have stopped childbearing, we need to move them onto long-acting methods of family planning. And that needs to be integrated into our programming pretty much right from the start. And for the Syrian response right now that we're in the 4th year, the actual life-saving classic type of interventions are actually a very small portion of what we are now doing with the refugees in the different countries where we are responding. And now this is also in Jordan. And these are, I know people always think of this as touchy-feely, warm and fuzzy type of stuff, not the critical interventions, because this is basically counseling as well as different types of activities that the young girls, women pick for themselves, like watching a movie or drawing or painting, etc., that are often so hard for us to convey why they're important to do. But the young girls and the women themselves will tell you that this is life-saving, because when you have been displaced for so long, you don't know when you're going back, you're out of school, you don't know what your future is, thoughts of suicide increase significantly. And these are the type of activities that enable them to cope with the displacement that they are dealing with. And they will tell you in their own words that this for them is what is life-saving in their particular situation. And I found that to be such a strong, it was such a powerful message when I was there. And again, it speaks to the integration, because with regard to gender-based violence, of course, it's really important to ensure a survivor has access to services within 72 hours of experiencing the violence. But then the issues that they deal with on a daily basis, 1 year, 2 year, 3 years, also require support in that regard. And therefore, a package of services and interventions in this particular context has to go beyond the classic humanitarian type activities that we're so fond of. So just to say, I mean, this is some numbers around Syria, but just to say, for the Syria response, for Syria as well as Lebanon, Jordan, Iraq, and to some extent Egypt, we're now talking about resilience. How do you deliver your interventions in this particular setting in such a way that you are building resilience amongst these women and girls and amongst the community? And for UNFPA now, in fact, next week, we're actually going to huddle and strategize on what this integrated package for addressing GBV in emergencies, what it will be. There's the next speaker, I'm sure, is my colleague who's going to be speaking about Ebola, so that will spare you trying to figure out what all these bubbles are. But I have two key messages with regard to Ebola. If there ever was a time for integration, it's in the Ebola response. Typically, when we are responding, when there's an acute phase of an emergency, we don't start talking about restoration of services and whatnot until 3 to 6 months into the disaster. With Ebola, we're talking about it right now. We recognize that Ebola has to be contained, but the devastation to health infrastructure in these countries is such that we know that we have to be doing that at the same time, and we have to be doing our emergency interventions in such a way that it is restoring services and building back the systems that have been destroyed. And I mean, the one point, or my last point with regard to community awareness and social mobilization is that, yes, all the other things are really important, but why this is particularly important is where there has been some, we're cautiously optimistic here, where there has been some decrease in Ebola has been due to behavior change. Communities adopting risk reduction behaviors. And the position has always been that that social change takes time, addressing social norms is a very long-term process. We've seen that happen with Ebola, not overnight, but in a much shorter time frame than we've ever experienced before. I'm from Nigeria. West Africa, as for a lot of parts of Africa, the rites for burial are they're deeply rooted in our culture, and burying your loved one is an honor. The rites that have to be performed before someone is buried is an honor for you to do it. But for people in these countries to have adopted safe burial and to basically do away with these rites is a major, major shift in the way that we have been, what we've been used to in terms of responding during emergency. So if we can change social norms when we're in an acute phase of an emergency such as it is for Ebola, we can really begin to think about what it is we do during emergencies and how we do it. And with that, these are just contact tracers. I won't go into that. And I know we don't have Q&A, but this little girl's eyes are ever so haunting and questioning. So I had to put in the picture. Thank you very much.
Thank you. And we will, of course, have opportunity for Q&A, but we tend to do that at the end. You know, the statistics that you provided, Ugo, I mean, of course, you know, we know women are disproportionately affected by a lot of things, including during times of crisis. But, you know, really just astonishing. I hadn't thought through 111 countries since 2008, 70 million pregnant women in unpeaceful countries. I mean, it's staggering. But, you know, I think we work on these things because something brought us in, right? Something struck us. And I have to say, a UNFPA safe birthing kit is one of the reasons I am sitting up here. Have you guys seen that? I should have, it's actually in the trunk of my car. And I keep it there because, you know, of doing presentations and going in and saying, you know, what we're talking about in reality is a plastic sheet, a clean razor blade, and a bar of soap, and a string to tie off the umbilical cord. These simple interventions, like we saw with the dignity kits, have such a huge impact. So I'm literally sitting here, partially my salary supported by UNFPA, but because of UNFPA and all the work they do, especially in some of the areas and some of what you were talking about, including the responses now around Ebola. And speaking of which, for those of you who signed up prior for this seminar prior to last Friday, probably did not see or probably noticed that John Walsh wasn't mentioned on the invitation, and that's because a colleague at the Maternal Health Task Force stumbled upon him last Friday and heard his story, and we had to add him. And it goes without saying that there were more detailed bios out front, but you may have noticed already that he is the Chief Clinical Officer for Ebola Response for Partners in Health. And that's just something he does in addition to being a senior nurse anesthesiast at Boston Children's Hospital and an associate in anesthesia at Harvard Medical School. So he's a busy man, and he actually just returned from working in Liberia on Ebola and maternal health response. But when I was introduced to him via email, an article was forwarded to me from a Boston-based newspaper, and there was a particular line in there that was striking, and that was him talking to his family about why he felt like he needed to go, and I think there was a line about how you were able to convince your mother, your sister, and your aunts by talking about the impact of Ebola on women. So I know that all of us are looking forward to hearing more about your experiences.
Thanks. So, hello, everybody. Thanks for having me. It's really quite an honor, and an honor to follow Ugo, because I know a lot of our work dovetails nicely onto what UNFPA is doing. So, for those of you who aren't familiar, Partners in Health is an NGO based in Boston. We were founded in the 80s by Paul Farmer, Jim Kim, Ophelia Dahl, and a great man called Tom White. And our work started in Haiti initially around tuberculosis and multi-drug resistant tuberculosis, and then, of course, HIV. And all of those things are such important aspects of global health, particularly because they do affect so many women and so many children. And I think for that reason, Partners in Health has always had a really strong interest in what we can do to raise the standard of care for maternal health in all the countries where we work. We're now in 12 countries. I think our biggest project until very recently was in Haiti. We have about a dozen hospitals and health centers, which now includes a 300-bed tertiary hospital in the Central Plateau, where we're providing very high-level modern care for a huge. Our catchment is our tertiary catchment is millions of people, and interestingly, we do about 80 C-sections a month there, which sounds. It's about a quarter of the women that we see that we deliver there. Sounds like a lot, but what we've found is that these are women who need C-sections, who didn't have access to that care elsewhere. And that's exciting to be a part of, but not what I'm here to talk about. So But just a little background about, who PIH is. So Partners in Health has been involved with the Ebola response for a bit over 2 months now. We got involved after some pretty heavy discussions between Jim Kim, who's now the president of the World Bank, and our founder, Paul Farmer, some other folks who were interested in what the international NGO community could do to help. We are not an emergency humanitarian response organization, though we were heavily involved with Haiti after the earthquake because we were there anyway. But we had an opportunity and came to a moment where we realized that if it's not us, then who is going to do this? MSF, IMC, many other NGOs put their hats in the ring to provide some type of support for the response. And we couldn't stand by as an organization and not do that. So now we're in Liberia and Sierra Leone. My work is primarily focused in Liberia at the moment. We are soon to open 2 of the most rural Ebola treatment units in Liberia, in Grand Jetty County and Maryland County. We also just today agreed to support what's called a community care center, which is a small Ebola unit, which is meant to provide the same standard of care and infection prevention and control and treatment and isolation and triage for Ebola patients in much more rural settings. So we'll support at least one emergency CCC in Riverside County, as well as supporting some rapid response for hotspots that are popping up. And this is what we're seeing at the moment. We have the epidemiology is changing. We're seeing where a few months ago there was a huge concentration of patients sick and dying in Monrovia and the very near counties. Those numbers have fallen. We've gone from around 100 new cases a day to about 20 new cases a day. But that's not as great as it sounds. Now we're seeing cases in every county in Liberia. And the same is true in Sierra Leone. We're seeing a much more widespread epidemic, which is much more dangerous and much more difficult to get the social mobilization, those messages, to get them out to the rural areas. And as an organization, and I think probably as a small part of a huge response, we have to recognize that it is the weakened and feeble health system that existed in Liberia prior to Ebola, which we could, if we take the long view and take a step back, secondary to many years of civil war, conflict, followed by some degree of peace and an attempt for development, followed by a horrendous epidemic. And this just goes to what we were kind of discussing before, which is that the breadth of these, the need for humanitarian aid is carrying on much longer than what we've ever seen before. I think you can't talk about the Ebola epidemic without talking about that feeble healthcare system. And we cannot divorce an Ebola response from what needs to happen to avoid this ever again. The first thing is recommencing essential health services, which is a lot of maternal and child health. I think it was UNFPA who said, who have estimated in West Africa there's 800,000 women estimated to deliver within the next 12 months. 1.2 million women will not have access to family planning because of the decimation of any semblance of a healthcare infrastructure that existed. If a tree falls in the woods, the tree still falls in the woods. And our responsibility is to call attention to the fact that there's an invisible crisis happening. Everybody wants to talk about Ebola, but there are women delivering at home. Before this outbreak, there were only 50% of women in Liberia had access to skilled birth attendants. The estimate is now that's down around 30%. The access to prenatal care was around 40%. It's down to 25%. Access to malaria prophylaxis for women, pregnant women, children, was about 50%. That's about half of that now. Around 2012, Liberia commenced a accelerated action plan to address some of these issues with maternal health and welfare, and went from around 1,000 deaths per 100,000 women down to around 775 or so, and all of that advancement is gone. There's not great data about what health facilities are open and available, but we do know that since this outbreak started, there have been 350 healthcare worker infections with almost 200 deaths. So if we say a healthcare facility is open, what does that mean? Does that address the fear that exists after these healthcare workers have watched their colleagues die? Does that address the questions around how to safely don the personal protective equipment and actually how to take it off, which is much more dangerous than putting it on? Is there continuous access? I know the UN and World Health Organization, many different organizations are working day and night, UNICEF, to provide continuous access to PPE and also to the training needed for infection prevention and control. The same is true for water, sanitation, and hygiene. Similar to the Dignity kits, UNICEF is providing some home care kits. We're not advocating for care of Ebola patients in one's home, but we're now talking about an epidemic that's reaching places that you fly in a helicopter and then hike for 2 hours just to reach a village. So we have to be creative in reaching these patients and providing dignified care to the patients, but also to raising the standard of care. Most of us have probably read or heard in the news, I think just yesterday maybe, NPR put out a piece about maternal mortality and infant mortality with Ebola, and it's abysmal. It's about 100%. There's not great data. There is a good series from MSF who describes their experience over the course of a few months treating a large number of patients. There's data from an outbreak maybe 10 years ago that it's around 96% mortality for pregnant women. With other types of viral hemorrhagic fever, like Lassa fever, the highest risk is in the third trimester. In Ebola, the risk is throughout the entire pregnancy. Very soon after infection, we see spontaneous abortion followed by uncontrolled hemorrhage. Safe delivery is virtually impossible at the moment. The volume of blood and amniotic fluid that a healthcare worker is exposed to puts them at enormous risk for nosocomial infection. And we have to take a step back and start to think about the ethics of these things. We as an organization, Partners in Health, always strives to raise the standard of care, to provide a preferential option for the poor. But the question becomes, at what cost do you provide that? Monetarily, we've never had a limit. We say you provide the care and pay the bills later, and we've certainly operated that way. But when it comes to the safety of people who, some of whom are volunteering their time, people who are taking time away from families and jobs here in the States and across the world, can we, and I don't have the answer to this, I guess I'm posing this to everyone, is can we put healthcare workers at this risk? And we want to save these women. We want to save these babies. We want to provide the highest level of care to every patient who's infected. But there's huge risk. So what does that mean for recommencement of essential health services? So I believe, and one of the things I'm pushing for and asking for is more ubiquitous access to Ebola testing. I think about, and those of us who have worked in developing and resource-limited settings have met in the middle of the night the late, the third trimester woman with infected with malaria. She's febrile. Perhaps she's preeclamptic or eclamptic, hypertensive. Maybe she's bleeding. Maybe she's had a seizure. She's postictal. At the moment in West Africa, if this woman arrives to a health facility, she will be sent to an Ebola treatment unit. That is case definition for Ebola. And we know that what that woman needs is to deliver. She needs a safe delivery. She needs to have a C-section. And particularly in the rural Southeast, where Partners in Health, with many other organizations are working, you can't provide it. It's days, 2, 3, 4 days to get that blood sample to the lab to get a result that says this woman's negative for Ebola and it's safe. So ubiquitous access to Ebola testing, pushing as hard as we can for a rapid diagnostic test, point of care test, tying health facilities to a triage center, and training maternal health workers, midwives, community health workers, family planners, training them in infection control and prevention, supporting them, providing them for years to come, decades to come. These teams will need to have access to PPE, to ongoing education, to water, sanitation, hygiene. That's what we have to do. That's how we take the next step and recommence essential health services. And then tie that, it has to be tied, Ebola response has to be tied to health system strengthening. So we don't have to see this again at all levels, the community level, primary care level, the district level. And so that's why, though we're not a humanitarian, sort of emergency humanitarian response NGO, we feel like we're particularly well placed to enter the field, provide immediate Ebola response, and stay. Partners in Health is in West Africa now at the invitation of the ministries of health in both Liberia and Sierra Leone to help them strengthen their health systems. I took a couple of notes, and I just to touch on what Ugo said about, again, to reiterate that an emergency response in this situation has to be tied to some sort of sustained effort. And we believe that really strongly. 70% of Ebola patients are women, and that's because they're the caretakers. They're the ones who stay by the side of their family member, who provide those traditional burials and try to provide for the dignity of their family. And so if nothing else, Ebola is a huge issue for women's health. And then the last piece that I wanted to touch on that really struck a chord was the idea of integration. And working in Liberia over the last 5 weeks or so, and I go back next week, there is fantastic integration between the Ministry of Health, all of the UN agencies, all of the international NGOs, Médecins Sans Frontières, who've been absolute heroes in this response. And so I hope that perhaps this is a dawn of a new day in humanitarian response, to see what can be achieved by every NGO coming together and saying, you know, we're going to handle safe burials, we're going to handle water and sanitation, we're going to take the healthcare piece, we're going to take the maternal health piece, and all of those agencies working together and trusting each other. All the resources are open source. Everybody has access to the same training, the same education, and the goal is only to stop Ebola. So that's where we're at. Thanks.
Thank you. You know, for those that are tweeting, if you didn't catch the term he used, invisible crisis, tweet it now, because I think that term said a lot, especially when we think about access to skilled birth attendants, and when we think about the statistics you gave around access to prenatal care now. I mean, invisible crisis is really the only words you can put towards that. Speaking of your they're not one-liners. Well, I guess we could call them one-liners. Another thing you said in your article, in the article that I read about you that really resonated, was that you said you wanted to be on the right side of history. And to me, I think some of the overlap between what Ugo was talking about and what John were talking about the need to strengthen health systems, about you know, having a sustained effort, the integration. I mean, that is all about being on the right side, and why, as Ugo said, you know, this is different, and this is when we really get to look at our responses. I mean, it is about being on the right side of history. So thank you for joining us, and also the point about, you know, care needing to be on a longer term now. It's different, and again, appreciate your thoughts on this, especially when you both recently come back from parts of the world, and we're getting to hear it firsthand so quickly. And while stats are still coming together, you know, we don't know what it really means yet in a lot of ways. It has been a couple of long months, but we don't know yet. We are now, and I'm not sure if I said this, because I've been looking forward to this so much, this panel, but if I didn't already say, you know, more detailed bios are available outside, because I want to move quickly and do the introductions quickly so we can hear from them. But I don't want to take away from the vast experiences the folks on the panels have had. We're now going to hear from Sarah Chinoway. She is the sexual and reproductive health and emergencies independent consultant, and so she's going to touch upon the variety of emergencies that she has either responded to or has knowledge around. So thank you.
Thank you very much. Thank you for having me here. It's lovely to be here. It's lovely to be here with my esteemed colleagues and some old friends from the fields. So today I'm going to talk a little bit about what is the international standard for reproductive health and emergencies? What should we be doing as international humanitarian aid workers? And what are some of the key challenges that we keep seeing over and over again in emergencies? What are the blockages? What are the challenges to ensuring that these services are implemented? This is the Interagency Field Manual for Reproductive Health in Humanitarian Crises. It sets forth the international guidelines on what we should be doing. The version on, let's see if I can push this little thing, yeah. So on your left, this was the 1999 version, and on your right, it was revised for 2010. And it outlines what comprehensive services which we should be providing, as well as the minimum package. At the beginning of a crisis, we can't do everything. We can't do cancer screenings. It's not appropriate. We don't have time. We have to choose and decide which activities we're going to focus on, and that's called the MISP. And I'm going to talk about that today. So there are 5 key objectives of the MISP, and then I'll go through and share some stories culled from the field about challenges in MISP implementation. So the first objective is you need coordination. You need an agency to coordinate the reproductive health response. That's really the keystone, the linchpin to ensuring that women and girls and all populations have access to reproductive health services. It's coordination. Preventing and managing sexual violence, so not all of gender-based violence, but focusing on sexual violence, reducing HIV transmission, preventing maternal and newborn death and disability, and then starting to plan for comprehensive services as soon as possible. So I'll go through these in detail. There's some more additions to this minimum package in the 2010 version of the field manual, but I don't think we'll have time to go through that today. So what should happen? There's a crisis. We can talk about Haiti, for example. There was the Haiti earthquake. What should happen immediately after that? Who does what for reproductive health specifically? The first thing that happens is that you need a leading reproductive health agency. Oftentimes that's UNFPA, who steps to the plate and coordinates. A focal point needs to be nominated, so one specific person to oversee that response, holding regular meetings, linking with the health cluster, and then ensuring that supplies are available. Oh, the picture isn't coming through very clearly. But this is a reproductive health coordination meeting on the Thai-Burma border, for example. There are a number of different agencies here. They came together bi-weekly. This is not during the acute phase of an emergency. But they were fantastic. Strategic planning, division of labor. This is what we want to see in a crisis, is agencies pulling together, working together, planning. The reality in terms of coordination challenges is historically, less so now, but historically there wasn't a lead reproductive health agency that was identified. There's high staff turnover, particularly of that reproductive health focal point in Haiti. Janet and I were in Haiti a few years ago after the earthquake, and we came in to do an assessment in month 4. There had been 5 reproductive health focal points at that point. Staff turnover really eroded some of the coordination. Individually, they were amazing coordinators, but you really need low staff turnover and somebody to pull it together. Also in Haiti, the meetings, the reproductive health meetings, were pretty inaccessible. They were on the UN log base, which prevented a number of local actors from being able to access meetings. Limited feedback loop with the health cluster, and there can be delays in reproductive health supplies. So this is a number of years ago. It's my colleague from UNFPA, Jonathan, and my colleague from the Women's Refugee Committee, Sandy. And these are reproductive health kits, which Ugo mentioned earlier. They're interagency, but they're managed by UNFPA. So this is, I think, South Darfur. UNFPA had such a difficult time getting the kits to Khartoum through all the different paperwork and issues. Finally, they got these kits to Darfur, and they had been sitting there for over a month because there was terrible insecurity. There was fighting all around. They weren't able to get the kits out into the field where they're needed. And these are some of the things that agencies face consistently. In terms of sexual violence, the standard is, and again, this is the acute phase, focusing on the priority interventions, is ensuring that rape survivors, have safe access to health facilities, that there's clinical care, that means treatment after rape, specifically post-exposure prophylaxis to minimize HIV transmission, emergency contraception to minimize pregnancy, and then ensuring that the community is aware of the services in place and why they should come forward. Sometimes people don't know the benefit of accessing care. So this is after the post-election violence in Kenya, and these are latrines, and this is what we want to see. These latrines are segregated, sex segregated, so men and women have different latrines. You can lock them on the inside. These sound like really basic interventions, but you would be surprised how inconsistently they're implemented in emergencies. And when this isn't in place, when you do have combined latrines that aren't locked, it places women at risk for sexual violence. So this is a great example. This is among Guatemalan refugees refugees in Guatemala rather. And MSF had created a flyer for refugees that they had distributed saying, this is where you can get care after rape. This is the reason that it can help you. These are some of the benefits. The challenges we see is that prevention is often not prioritized. Prevention often gets sidelined. Psychosocial care is very important, but sometimes that is privileged at the expense of clinical care, and we really want to make sure that rape survivors have access to post-exposure prophylaxis, minimize their chances of pregnancy. Healthcare workers need specific training in caring for a rape survivor. This is also limited in emergencies. Again, a community might not be aware, and there's cultural stigma and shame that preventing women from coming forward. This is a rape survivor I interviewed in Iraq, an Iraqi rape survivor in Jordan, again, a number of years ago. We blurred out her face for confidentiality purposes. And her husband she was working for the Red Cross, and as retaliation for that, she was kidnapped for a few weeks. She was 8 months pregnant. She was raped repeatedly. And after that horrific ordeal, she was so ashamed and so terrified to come forward to access care. And she also didn't really understand what some of the benefits were. Later on, she did access care after bleeding, and she had a number of complications with her pregnancy. But we want to not just tell people, or not just ensure that services are available, this idea that if we build it, they will come. That's just not true when it comes to reproductive health. We need to engage communities. We need to make sure that women feel safe coming forward, that we're providing them with good services, and that they know why they should come forward. In terms of minimizing HIV transmission, the key activities are to ensure that standard precautions are enforced, that free condoms are available, and that there is safe blood transfusion. So again, it's my old boss, Sandy, at the Women's Refugee Commission. We did a lot of field missions together. So this is the post-election violence in Kenya. She's very thrilled to see this condom dispenser. A lot of times when you do a reproductive health assessment and you go to a clinic and you ask them, oh, are condoms available for the community? They'll say, oh, yeah, yes, absolutely. They're here in my drawer, which no one's going to ask you for a condom. Like, that's just, especially adolescents, people who are unmarried. It's very uncomfortable for people to go to a clinic, ask a healthcare worker for a condom. We want to make sure that they are available, visible, people can discreetly take them. What we see in terms of challenges regarding HIV, condoms, sometimes there's a sense that, oh, well, this is a really conservative community, we can't make condoms available. It will be offensive. Or let's spend the time at the beginning of a crisis doing a big condom campaign to educate the community. We don't have time for that. This is the acute phase. We want to focus on the clinical priority interventions. So we want to make sure that condoms are available, but we don't want to spend too much time building campaigns either. Health workers, they might take shortcuts. There might be shortage of supplies, so they're not able to adhere to standard precautions. Blood for transfusion might not be screened, and poor medical waste management it can also be an issue in a number of settings. This is in Mindanao, and it was a pit that for waste disposal that actually technically should have been okay. It had a cover, it had sort of a fence around it, but what ended up happening here is some populations are very desperate, so they will scavenge. They'll scavenge for syringes or other medical supplies, wash them out, resell them to pharmacies. Obviously, that's a big risk. So we want to make sure that waste disposal is taken care of properly. So objective 4, our priority is to prevent maternal and newborn death and disability. And this is making sure that women have access to emergency obstetric and newborn care, that there's 24/7 referral systems established. Women will give birth anytime, day or night. We know this. We need to make sure that they have access to this care and that there are clean delivery kits available. I don't know if some of you remember this story. It still sticks with me. It's amazing. Sophia, this woman here, this is in 2000, a long time ago, the Mozambique floods. There were horrendous floods. She climbed this tree. She went into labor and gave birth all by herself. And 4 days later, she was rescued, and she's fine. Her and her baby was fine. We're fine. This is just to highlight women will give birth anywhere, anytime. In terms of, this is Cyclone Nargis response in 2008 in Myanmar and Burma. You can see here UNFPA was giving out dignity kits. I really have to give major props to UNFPA. The reproductive health response after Cyclone Nargis was the best I have ever seen. It was absolutely incredible. We have so much we can learn from them in terms of coordination, working with partners, linkages with development actors. Incredible. That's another presentation. And here, this is another example of innovation and really what's the priority? The priority is to get women access to emergency obstetric care. So UNFPA and partners had actually rented some boats, or bought some boats rather, and because the roads were all wiped out, completely destroyed. A lot of debris. And so UNFPA and their partners, they got boats and were transporting women to hospitals via the river. It was fantastic. And that's this type of creative thinking we want to see in emergencies. Some of the major challenges, health facilities are destroyed, transportation challenges, we see that with insecurity, lack of communication system, and the community might not be aware of services. Also, there was a study done in 2012. There's very little research on reproductive health and emergencies, so I just stuck this up here, that looked at what are the major challenges for newborn care in humanitarian settings. The number one was funding shortages. Donors aren't funding this. There's been a global evaluation done that shows increased funding overall for reproductive health and emergencies, but we still have a lot of gaps, and for newborn care in particular. This woman, this was on Janet and my Haiti assessment a number of years ago. This was outside of Port-au-Prince, and she was 8 months pregnant. This was 4 months after the earthquake. She had only seen, I think there had been a mobile clinic once that came through. She didn't have access to care. The referral hospital was a very long ways away. She was going into labor soon. What's going to happen to her? How is she going to get care? She didn't have a birth kit. Thank you. And care was very far away. And these are some of the things that we need to address. The final objective, we need to start planning for comprehensive services. We want these communities to have comprehensive care as soon as possible. So we need to start planning for that early on, identifying gaps like, okay, there are very few people here who are able to provide clinical management of rape, so we need to set up a training as soon as possible. Where can we start providing future, more comprehensive services? Maybe we're just providing reproductive health care in mobile clinics or tent clinics. Where can we start providing more systematic care? Ordering supplies, we can't rely on those reproductive health kits for the long term. Those reproductive health kits are for short term. We need to start ordering supplies through regular supply chains. So some of the challenges, procurement challenges, it's hard to collect data. Sites for delivery of reproductive health services, they still might be under construction, and this component is often neglected. Everybody's so overwhelmed with the other components of the MISP, this often falls by the wayside. This is in the Philippines. This is an MSF hospital. MSF, I think, is the only agency that can set up a hospital if I can't remember exactly how they do it. I think it's within 72 hours, 48 or 72 hours. If people are working around the clock, they can set up a completely self-sustaining hospital. It's incredible. So this is excellent for the acute phase. We need this when there's been major destruction of health facilities, women who need obstetric care that can get sent to these tent hospitals. But what happens when MSF pulls out and the referral hospital hasn't been rehabilitated yet? What happens during that gap? It highlights what a number of my other colleagues were saying of linking with development actors and making sure that there's a more smooth transition. So in terms of the key enablers, what are the key things that we see in the field that helps these services be put in place? And I've just pulled these together. We need to have a lead reproductive health agency consistently. Again, this is often UNFPA. Effective leadership, we need a strong reproductive health focal point, somebody who has a lot of chutzpah, who can really stand up to people who say, well, reproductive health isn't a priority, it's not important, we need to focus on, say, infectious disease. You need someone who's strong, who's a real advocate, who can work with people and pull people together. One of the really interesting things I found actually in my dissertation research is one of the key enablers for any sort of emergency response, also in military response, is trust among partners. So really trusting and working together is very important. You can have all the experts on the ground, but if it's fragmented, they're not working together, you're going to have a fragmented response. So we see that as well in the reproductive health response. We need to coordinate, but it's really beyond coordination. We need to build those linkages. And again, it goes back to bridging that development and humanitarian divide. We want to see national ownership of the reproductive health response. I'd like to work myself out of a job someday. Really, we want to see the Ministry of Health taking the lead. We want to see national actors sitting around the table leading that response. Low staff turnover. Again, that goes back to often national actors. We want them to be involved and leading it. And finally, community engagement. This is really important. We can't just fly in and provide services and expect people to come. We need women and girls and communities to be involved in the programs that affect their own lives. So when you're in the field, I highly encourage you, reach out, talk to women, just talk to them. Hold focus group discussions, engage them as much as possible, and it will improve your reproductive health response. Thank you very much.
I certainly appreciated how you ended your comments. I mean, I think that's really critical when we talk about any of our work, incorporating community engagement, especially that of women and girls. I think a theme that now I've seen come across all our speakers now is dignified care, whether that's, not only just making sure that we get to the areas, but that we get to those areas and aren't just having things in drawers or assuming communities don't need or want access to things like condoms. I think those were some really important points that you made. I do want to break for 1 second to just ask if anybody has any clarifying questions. So nothing about content, please, because we do want to have a robust discussion towards the end. But is there anything that we've heard from our first 3 speakers that needs any clarification, a repeat on any stats, anything to that effect? Or are we ready to move on? Good. Well, I thought they were all very clear, too. I didn't think it was necessary. So as I said, we've, this is a different model for us. I've moderated 5 people, never 6. But it's just very interesting whether folks have been referred to us from amazing work being featured in papers and knowing friends at coffee shops, or quite frankly, when I get those emails from folks, and I think a lot of you probably know Annie Turo, and I got an email a few months ago that said, you know what, Sandeep, you really need to do an event that talks about maternal health and gender-based violence and conflict. And I was like, well, I am actually on November 20th. So that's how Janet got linked to the panel. Someone had a premonition that we were doing this. And so she is the Deputy Director of Health Policy and Practice for International Medical Corps, and she's going to talk to us today a little bit, or quite a bit, about their efforts. And you're going to hear some of the terminology that we heard Sarah mentioned around the minimum initial service package. We're also going to hear a little bit more about gender-based violence from her as well. Your efforts. Thank you.
Okay, thank you, Sandeep. And yes, I'm also really thrilled to be here with a lot of old friends and colleagues and meeting some new faces as well. And, to all be here together talking about a really, really important issue about, the sexual and reproductive health needs of populations in crisis situations and, the period of transition afterwards. And we've been talking a lot about different numbers and the impact of or the issue of there being more and more crises these days, and the crises have just grown. There's more natural disasters, there's more conflict-related disasters, and so the numbers of affected people just keep on growing. And I just wanted to highlight the fact that also the most IDPs are now in sub-Saharan Africa and followed by the Middle East, and but yet we have IDPs and refugees all over the world. And so I just wanted to, I think we've already talked quite a bit about what are some of the different impacts of emergencies on maternal health and adolescent health. I just wanted to also highlight the fact that a third of the maternal deaths worldwide are usually occur in a crisis setting, and that the highest maternal mortality ratios are usually in countries that are affected by conflict. And, we've also talked about the numbers of pregnant women, but that, once again, another way to remember it is maybe to think about the fact that approximately 4% of a population in a crisis setting is pregnant. And so that's a lot of people to be thinking about and to, with different needs. So just a little bit about International Medical Corps. We started out doing humanitarian response, and we continue to do a lot of humanitarian response. Our activities started in the 80s, very similar to Partners in Health, I guess. And but we started our work in Afghanistan, and we're currently working in about 30 countries. It can be very dynamic due to the nature of our work. And we also do more and more development programming, and we're seeking to bridge a lot more of the emergency response with longer-term development, and something that's already been talked about by my colleagues that have already presented. Also, just to highlight that these are the countries that we're currently doing sexual and reproductive health programming in. We probably do some aspects of it in some of the other countries where we work. And to highlight that 17 of these 20 countries are ones that are either in, an acute crisis situation or more of a protracted crisis. And these can be natural disaster related or conflict related. And we're doing the MISP. You just learned all about the MISP. So we are implementing the MISP in 12 countries, and family planning programs, which is also part of that extra MISP, the MISP Plus from 2010 on. We're doing family planning more and more, and integrating that into the programs and currently in 13 countries. We also do a lot of work in gender-based violence, including case management for sexual violence and clinical management of rape, and take a much broader approach to the treatment of sexual violence, as Sarah was talking about, the importance of, providing that dignified care and the importance of providing that case management support, as opposed to just focusing on making sure that all the providers are trained, because if that's all we do, it does not ensure at all that the women, or sometimes men, boys, girls, who have been raped or who have been sexually assaulted are going to come and seek any services at all. And trust, of course, is just a critical piece. And we're beginning to do more adolescent sexual reproductive health programming, and currently have that programming in 6 countries. And so just some big numbers in terms of numbers of health providers that have been trained in clinical management of rape, including the case management approach. This is at the global level with IMC. And even more people have been trained on the guiding principles related to gender-based violence. And once again, that starts to create that environment that will make it easier for women and girls and others that have been affected to seek the care that they need. And so over 12,000 survivors of sexual assault were treated in IMC-supported facilities over the last year. And also just wanted to highlight that, we've trained about 1,500 providers in concepts related to maternal newborn health. Oftentimes, this is a pretty broad term, but oftentimes there are these very short refresher courses that we will do in an emergency setting. And so focusing more on family planning and emergency obstetric and newborn care, beginning to do a little bit more with the newborn care. But once again, that group tends to, that population does not tend to get the focus that it needs. And so we've had 43,000 plus new users for family planning. Sarah presented this interagency field manual that's been developed for reproductive health and emergencies. And this framework for responding to SRH and emergencies was developed by that group, and I think nicely presents what others have already been talking about, that, you know, when the emergency hits, yes, it's critical to make the services available, but you need to, from the moment that the emergency starts, it's really critical to start planning for that more comprehensive approach and be integrating the more comprehensive approach as you can all along the way. And so that's what we try to do in our programming. And so I just wanted to put up here from the humanitarian perspective, these are the sorts of maps that we operate from, I guess, in coordinating emergency responses. The UN OCHA puts these out and really assists in that broader coordination to identify, who's doing what, where are the biggest, where are the larger populations of IDPs, the camps, the refugees. So I'm going to talk about our work in South Sudan and where we are working in a number of different types of programs, but I will focus on 5 where we are providing the MISP and beginning to add a few more activities as well. And these are programs that are that started up after the December 2013 civil conflict. And since then, unfortunately, the number of IDPs has only continued to grow. And so currently in South Sudan, there's about 1.4, there might even 1.4 million IDPs, and there may even be more now, but that was as of October. And so we have been working in Juba in a couple of areas that are protected areas. They're called POCs, protection of civilian sites. And those tend to be around the UN compounds where the population felt like they could at least get the most security that was available in the areas. So there's a couple of POCs we're working in around Juba, and then we're working in a couple of other sites, Awariel and Malakal, and then we're working in a couple of camps in Maban where there have been IDPs and refugees for a much longer period of time. And so you heard Sarah talking about all the different objectives of the MISP, and so I just wanted to highlight that we are very actively participating in the reproductive health coordination that takes place in Juba, and it's UNFPA and Ministry of Health that are taking a lead on that coordination. And it's been becoming stronger and stronger. I think one of the challenges has been that there's not coordination at all of the other sites and as you saw from that map that I just showed you, there are so many different sites with IDPs and with the POC areas or populations that are not gathered in any kind of a camp, but that are just living in the surrounding area. And so it's very difficult to decentralize that reproductive health coordination, but that would be helpful in some of the other sites. We also are very active in the GBV coordination, and this is a group that coordinates quite a bit with the reproductive health group as well as the health cluster. And the GBV coordination has decentralized somewhat, and we've seen that there's more of those groups in some of the other more peripheral sites. So there's been a lot of focus on prevention and management of sexual violence and training our healthcare workers and making the services available in all of the places where we're providing primary health care as well as the sexual reproductive health services. And we're also working on the prevention of HIV transmission through making the condoms available and also really focusing on safe blood transfusions. That's working through partners. And again, when I was looking at the data from the different projects, I would say, we're more assured that there's safe blood transfusions around Juba. It's not as clear how that works in some of the other sites where we're working. There have been shortages of condoms at different times, and so that continues to be an issue at times. PMTCT, for prevention of maternal to child transmission, has actually been made available around Juba, and that's been in partnership with the Ministry of Health and their HIV/AIDS department. So that's been fantastic. And so the focus of our activities to prevent excess maternal and newborn morbidity and mortality has been, to make the emergency obstetric care services available. And so those have been made available in Juba, in one of the POCs there, and in most of the other sites we have a referral system in place to ensure access to EMOC. And we're working to provide the assisted delivery and family planning and newborn care. And the Dignity Kits we've also been able to distribute in most of these sites, and that's been done in partnership with UNFPA as well as many other partners who have given us the Dignity Kits since we had access to additional populations. We've also been able to do some integration with nutrition, and integration is something that we've been talking about here as well, and that there just needs to be more and more of a focus on that integration. And when you're working with pregnant and lactating women, I mean, obviously you should be having a nutrition component to that. So that's an area that we would also at IMC like to just start having more of a focus on. And then as we have been going along that continuum to providing more comprehensive SRH programming, we have integrated active management of third stage of labor, for example, into our care, into the delivery care as quickly as possible. And so that's just an additional comprehensive focus that we've taken. That way we can at least prevent some of those emergencies that we have to have the EMOC services available for. I would say for staffing, we have needed to hire a lot of expat healthcare providers because there's just a health worker shortage and in South Sudan. And it's an example of many other places, too, that have been in a protracted crisis situation where schools, everything has ground to a halt. And a lot of people have maybe gone through short courses that have been very useful, but they're maybe 6 months, 9 months, at best, or maybe 18 months, but they still don't have the level of training that's really needed to be able to provide the EMOC services, for example, that we need to ensure are available. So again, we've had a really good partnership with UNFPA where they had a number of midwives that were available to work and provide SRH services. So we have placed them in all 5 of these areas. And in fact, you'll see that there's these pictures are not showing up very well, but there's a midwife that's working with us in one of the POCs, providing newborn care. And then we also have some midwives that we've hired and oftentimes work a lot with the traditional birth attendants, of course, who are really helping us make a link with the communities and providing referrals as well as working the night shift or staying on call and making sure that they contact the qualified provider on call when needed during the night. Thank you. Just one innovation I wanted to highlight too in our team is that since we have a very comprehensive program in South Sudan, more than in some of the other places, we do have a lot of experts within IMC and within a lot of other agencies. And so our reproductive health officer actually set up a speakers bureau so that she could, harness all of this expertise and conduct a regular refresher training for 1 or 2 days on a monthly basis and based upon topics that people were asking to be trained on. I just wanted to show a little bit of data from these 5 sites to show data collection can be very challenging in some of these settings, and so we're not even sure that this captures everything. But as you can see, there's just kind of a rise and fall in deliveries. But there was really a drop in assisted deliveries around August, and that's when there was a lot of civil unrest in the sites in those 2 sites in particular where we were working. And so our staff had to be evacuated. And so therefore the services come to a halt. And then you have to try to build them back up again. And sometimes the facility gets looted and everything's gone. And then you have to get more supplies and really start over again. This is just a picture of our EMOC facility in Juba. There you'll see a big drop in family planning services as well, and that was at Maban camp where we had a lot of insecurity and everybody was evacuated. You'll see that there's quite a nice rise in number of family planning users in Malakal, and that's mostly related to the fact that we had enough skilled providers in the facility, and so they felt like they could also take the time to provide family planning. And so just more pictures of health education that's being provided at the Reproductive Health Center. I was mostly using South Sudan as an example, but thought I would just share an integrated approach that we're using in Gambela Refugee Camp, another site in a site where there's a lot of South Sudanese refugees that poured in there after the December 2013 crisis. And so we've had a very nice partnership with Sprint, who does a lot of work on MISP, and so they funded us to do quite a bit of training, and we trained the local Ethiopian NGO health providers on MISP. And we're providing pretty much all the services we were talking about. I think the thing to maybe highlight here is that we did bring in youth clubs in this one, and it's an integrated program where we have maternal health and GBV, prevention and response, and SRH. And so it's really, I think by bringing in these youth clubs, it's really allowed for there to be that creation of a safer space, something that other people have already been talking about. And so we were also talking about the importance of health system strengthening and really working on that from the very beginning of an emergency response. And so we've been really fortunate to have funding from UNFPA and the Canadian CEDA to implement to manage 3 midwifery schools, and actually 2 of them have a nursing program as well, and in South Sudan. And so here's just a couple of pictures, few pictures of them. The bottom left corner is just the site where they do their practicum that I thought I would highlight. The top 2 photos are 2 of our schools, one in Kajukeji and one in Wau. And so there's a lot of mannequins that actually UNFPA provided, and we just have rooms of these, many more than I ever had when I went to nursing school, to learn on. And a couple of our students at the Kajukeji program, and they're on the bottom left, they're doing their education session as part of antenatal care. It's maybe difficult to read this, but I just wanted to show some numbers in terms of numbers of students that we have, numbers of tutors that we have. We don't have enough tutors. We're constantly trying to have more tutors to really meet the norms and standards as set forth by the International Confederation of Midwives, but we're working on it. And so we've had usually around a lot more women than men in the programs, and we're usually about 30 to a class. And I'm missing a slide. Okay, sorry. I was just going to highlight, too, that all of them are working when they graduate. The only one that is not working is somebody who died in December 2013 during the conflict. So just to highlight again what people are dealing with. So really critical to being able to implement SRH in emergencies, again, is these partnerships. And the interagency working group that we've talked about and that has facilitated having this manual is really a fantastic convening group for those that are working on SRH and brings together those working in development, those working in emergency response. And UNFPA is a critical partner. I was talking about their support for the schools. They've also provided, staff to work with us, and of course they also facilitate access to the reproductive health kits, and that are so critical at the beginning of the emergency. And so that's more in global sense, but there are many other partners, but I wanted to highlight those. And the ministries of health, we always work with whenever they're able to also participate in the coordination. In some emergencies, they're not able to do that right away. For example, in Haiti, right after the earthquake, and the Ministry of Health their building was devastated. And so staff were having to work in parking lots or wherever. So then we step in, and the international community does much more of that work. In South Sudan, we have a number of partners that have been giving us a variety of support. One thing to highlight maybe is the misoprostol for the active management of third stage of labor. And in South Sudan, we have multiple donors, so I didn't list them all here. In Ethiopia, we've had support from BPRM and UNHCR, and I mentioned Sprint. And so just in terms of challenges, I just jotted down a few. I think there's probably some other higher level ones, come to think of it. But, the stockouts of supplies in South Sudan were quite specific from my team, but I know that they've had challenges, due to transportation sometimes, or due to the supply chain, or due to rainy season and not being able to get things in. So you need to pre-stock, pre-supply things. And if you have a very tight supply chain, then it's difficult to do your pre-stock. And the shortage of skilled personnel, which I was talking about already, and the fact, one really critical issue that was cited in Juba POC is that we don't have C-sections available at night. And as we know, there are deliveries any time of day. The emergency can happen anytime, but it's due to security issues. We haven't been able to resolve that problem. There are women who are more comfortable delivering at home. And so I think many of these things have been talked about. And I think there are many things that other people have already spoken about. We are talking about having maternal waiting homes in South Sudan, so the women can stay there when they're getting close to their delivery, so they have access to emergency obstetric care. And we also provide incentives to the traditional birth attendants, for referring women for deliveries, antenatal care, which is very critical. I think this is kind of more overarching challenges, and I think I'll just let you kind of read those. That this issue of having a supportive environment for people to be able to look for services and to actually receive them just cannot be stressed enough, and that can be very challenging to focus on when you're in an acute crisis setting. And cold chain is a really big problem in many situations, and oxytocin, which is the preferred drug for active management of third stage of labor, requires refrigeration, and so that can really be challenging, and therefore why misoprostol is a drug that we're trying to be able to make more and more available in these settings so that women can get active management of third stage of labor. And I would say another really key thing is to spend more time on, training our healthcare providers, helping them really be in touch with their own values related to SRH, and then work with them to, set those aside and to be able to provide respectful care and give people dignity and confidentiality of services. So thank you.
I think what was particularly interesting for me, at least through your presentation, were those graphs and the anecdotes that go with why you saw the drops when you saw whether it was staff needing to be evacuated, that facilities were looted. I mean, what we're talking about is real, and seeing it in those graph forms was particularly striking for me. And I also really appreciated, the examples of integration. We've certainly been talking about it, and we know from our experiences, but hearing about the integration with nutrition programs, for example, when it comes to pregnant and lactating women was particularly interesting for me. We are now going to hear from Melissa Scherer. She is a project director at John Snow International, and so she's going to talk to us a bit more about ultimate sustainability and what that means when working with places.
Again, I'd like to say that I'm really honored to be here on this panel with people I've known for a long time, and then the new head of UNFPA. Welcome, and well, the new head of the humanitarian unit, and Partners in Health, who's a little bit of a new face for us in the humanitarian world. And I'm really thankful for Danae, who's going last and not me. So hopefully I can keep you all awake for her presentation. So what I'm really going to talk about
Oh,
is
it's gonna be very interesting. You'll be
is a few gaps in the humanitarian service, one focused on a technical issue, emergency contraception, and one focused on an approach, working in partnership with local organizations. So numbers, we've all seen them. There's a lot. It's increasingly getting worse and worse. The context in relation to emergency contraception, women and girls have fled. A lot of times when they're fleeing, they don't bring their contraceptions. They don't have access to it, especially emergency contraception. And we've talked a little bit about the increased risk of gender-based violence. Sarah showed great photos of the toilets with the locks, sexual exploitation by persons in authority, even including camp representatives, bandits, host, receptor, community officials, is a real reality for most girls, adolescents, and women. Collecting firewood, using sex for survival, these are all things that increase in humanitarian settings. Emergency contraceptive, it's the least known, the least available, and the least used modern family planning method in developing countries. So recently a group of us got together from Population Council, Women's Refugee Committee, ICEC, and JSI, and we talked about holding a symposium. We realized we didn't really know what was going on with EC in humanitarian settings. So where do you go when you don't know? We devised a 10 to 15 question SurveyMonkey, because SurveyMonkey is the answer to all. And what we did was we talked to some of the people on this panel and in the room about, would your staff members in the field answer SurveyMonkey if we pushed it out through the interagency working group, which was mentioned, and again, it's a great resource. And they said yes, and so we were really, really surprised because the responses started flooding in within 2 weeks. We had over 100 respondents. CARE, some people from CARE decided to translate it into French to make sure their French-speaking providers would be able to access SurveyMonkey and answer it. And what we found, again, over 100 people responded, working in 37 countries. We were very surprised. 86% of the respondents stated they used EC. So we were all kind of shocked that they were saying they were using it. Where were they using it? In MCH clinics. Most of them were in camp settings. Most of it was tied to post-rape and GBV services. The majority were using a dedicated product, so like an EC product, about 81%. Some were reconfiguring oral contraceptive pills, about 56%, and a really high rate of people saying they used IUDs, which is 38% of people who said that in our results. What are the big barriers? Janet talked about the reality of the barriers, and you saw she kept flicking through the slides at the end. And here are some more challenges, and then some more challenges. But you saw a lot of stuff related to supply chain there, and that was the biggest barrier that we found. 69% talked about the logistics challenges with procuring EC. This is not atypical in normal development settings that EC is difficult to forecast. A lot of times the logistics data is unreliable for EC. It's unpredictable demand. Again, EC is not intended for regular use as a family planning method. It's heavily contingent on client and provider awareness, which is a big thing. People have to know that EC exists, providers have to know EC exists, and providers need to know the facts behind EC, not kind of their cultural and the barriers that are internal to themselves. And it's not mainstreamed into logistical reporting forms. So even when logistics have drug supplies, mostly in non-conflict settings, it's not there. So in conflict settings, it's even less likely to be there. How does EC get to services in crisis? As you can see, there's kind of a breaking between about half of it's coming from the public sector, so UN, agencies, contraception kits, and public sector government, and then about a third is coming from the private sector. And then we heard at this presentation, Janet again presented on IMC's experience with EC, and she talked about stories of in the Philippines people taking it out of the sexual violence kit. I think it's kit number 4 at UNFPA, and EC is included in it. And when it came into the country, people would actually take out EC, thinking that it was an abortifacient. So these are some of the challenges that are happening in the field. This is data from USA Delivers program. They surveyed over 40 countries. Some are conflict, DRC, South Sudan. Others are more developing countries. But this is the reality. About 81% of EC is sourced through the commercial sector by people, and that's, of course, because it's more confidential. There's flexible hours. They have more access to it. The gaps are that we need to be aware of is that, of course, people who have money and who are wealthy are able to access this. So what about those who don't? And there's a lack of private sector in crisis settings, and there's even a lack of data among collecting data among the private commercial sector. So in the public sector, about 55% or 60% via NGOs and via public sector. Of course, it's much more affordable via NGOs and the government. But in most crisis settings, there is no private sector. So again, the public sector is going to be higher, which we saw in the last slide. And I think the NGOs, like us, the onus is on us to ensure that EC is a part of our comprehensive reproductive health program in crisis settings. So this is again from the SurveyMonkey. And the good news is that EC is integrated for the most part into the supply chains, even though access is limited. When you think about supply chain, what do you need to do to make sure you can get there? There's 3 or 4 things you really need to look at. You need to look at what is on the National Essentials Medicine list for the country. And in this 2011 survey that I talked about, only 65% of the countries, of those 40 countries, had EC on the list. So there's opportunities there because as lists get updated, for instance, in Rwanda and Senegal, lists got updated in, I think, 2011. They put EC on there. And the other opportunity is a lot of conflict settings use the WHO the WHO list. So they just adopt their list for the National Essential Medicines, and it is on that. So these are 2 great things, structural barriers that are kind of helpful as we go forward. The other thing you need to think about with supply chain is registration and licensing. And I'm going to talk about some time that JSI employees spent in Syria, where EC is not registered, and some of the barriers there with the Jordanian refugees in a few slides. But this, of course, affects which brands are available. Now, again, there are some opportunities that exist that we all need to know about as we go into these countries. Specifically, WHO has pre-approved levonorgestrel. Sorry, I can never pronounce it. And 152 countries do have registered EC products. And there's a great, the website here has a great map and a database of what brand names and what EC is available for each country. So I'd encourage you to look at those 2 websites for more information. What you need to consider with supply chain. I talked to, at JSI where I work, there's a lot of logistics specialists. And what they told me is it's not like you can't forecast for EC. It's just you have to understand what your risk is. You have to be comfortable with the risk that you're able to forecast and be comfortable with the fact that you're probably not going to meet the need and there's going to be stockouts because that's what happens in every country. So it's still going to be looked at as what's happening in conflict settings, but it's just going to be exacerbated. So for forecasting, you're looking at sales data, demographic data, and consumption data, all which don't really exist in humanitarian settings. You're looking at routine data collection, again, something that's a real luxury. And you remember from Janet's slide, she talked about her data collection and how scant it still was, even though they're prioritizing it. So it's just something that we have to be aware of that's weak. In terms of service delivery, there's issues related to provider training, provider attitudes, looking at EC counseling to improve reproductive health of women, and especially looking at young women and adolescents, which is a huge issue. So I just wanted to show this slide again where the first issue is logistics and stockout with access to EC. But 2, 3, and 4, lack of understanding, stigma and beliefs that it's an abortifacient, stigma and beliefs that EC is not appropriate for adolescents and young women. So all of those you can kind of collapse together as provider barriers. So stuff that's happening when a young woman or a woman comes in to access EC, like the EC's in the pocket or the EC's in the drawer, like they were saying with the condoms. And who I decide to offer that option to is going to be based on what my belief system is. And so just addressing that at the on-front is really critical, I think, for all of our agencies. And I know IMC in particular and others in care have done a lot of work on that issue. So what we did, an employee of JSI over the summer, Jessica Barnett, we linked in with IMC and sent her to Jordan to see what was really happening there. She was able to meet with some key people and talk to them. EC is not registered in Jordan. It is also not registered in Syria. And again, another shout out to UNFPA. They're working, I think, really, really hard to try to get it registered. But this is a quote from her interview with the Ministry of Health representative. Even if we promoted EC, are we promoting sex? Would this be an easy recipe? So it just shows you that, there are a lot of barriers, there's a lot of stigma around it, there's a lot of lack of understanding of what it is. This is a quote from a UNHCR rep in Syria, and it really gives a shout out to UNFPA, I think. It takes several years, and it talks about the challenges of EC registration if it's not registered in the country. It takes several years to get drugs registered. The pushes come to the manufacturer, and then it has to come from outside the country, so there's all of these levels and layers that are really complex. And again, in Syria in particular, UNFPA is really struggling to try and get this done, but it's not like an easy solution. There's an issue with affordability too, and a lot of the refugees are accessing private services because there's stigma that we all kind of talked about among the providers in a lot of host countries about who these refugees are and them being second-class citizens. So this is an issue too related to accessing EC and other health care. So just in summary, for the logistics side of thing, we really need to, when we go into a conflict setting, we need to look at both the public and private options for EC. We need to integrate RH programming. Ding, ding, ding. That should be a buzzword. Hashtag integrate. We need to get data. So we need to look at what's on the National Essential Medical List in the country of where the refugees are and also in their home country. We need to address the attitudes and accessibility issues at the front lines, so in our own organizations with our own workers or with our partners. I'm just going to shift gears a little bit to approach, to kind of talk about an approach that's lacking and needs to be strengthened, I think, in a lot of our response. Partnership and capacity building, the missed opportunities graphic that's there, that came out in 2013, talking about how we're underutilizing local NGOs. And there's really three kind of models, and we've talked about a lot of them today. The vertical model is the MSF model, those beautiful hospitals that can be built in 48 hours, absolutely necessary and essential, but what happens when they go? And I think Liberia, when a lot of the international NGOs left, I think 08? I think it was 08 was when a lot of them left, and what's happened since then in the last 6 years hasn't been enough to make sure that Ebola was tightened really quickly. The hybrid INGO state model, when the INGO works with the government to provide services, a lot of people at this table do that, and then the hybrid INGO civil society, so when we work with local partners. This is kind of the partnership model, and that arrow that goes back and forth is like a black box. The Southern NGO usually wants funds, rightly so. The Northern NGO wants to give skills and strengthen and help the Southern NGO scale up. And there's a lot of problems with that and miscommunication. So there's a higher level of connectedness when you work with local NGOs, but there's a lot of lack of ability to measure growth in terms of their organizational capacity and their technical capacity to actually do the scale up that's needed. And they have usually a lot of the local partners that we work with are small boutique, like if they're working in Kakuma refugee camp, they're working in like 2 districts in it out of 10. So that's an issue for Northern NGOs when you work in partnership. What JSI does is we try to work in partnership. We're not, we don't do humanitarian work per se, but we work in Pakistan and in Kakuma refugee camp with partners. And Frontier Primary Health Clinic works in Northwest Frontier Province, which is now KPK, Khyber. Yeah, I know. So it's KPK now. Pakhtunkhwa, I think, is how you pronounce it, but I'm not quite sure. But we selected a local partner who is actually doing reproductive health via Lady Health Workers. They're doing transferring skills through a local organization, looking at RH information, looking at capacity building, strengthening their own internal management system. That's our role in pushing them to increase the network and do the coordination that's so important as part of the MISP. And that is my end, and I didn't get any minutes, so hopefully that wasn't too long. But I'd like to summarize by just saying, we've come so far in this fight. I've been working in it for a long time, and many people sitting here have been working it longer and in the room as well. But I feel like there's so much more work to be done. And then I also want to end with one of my favorite quotes from Martin Luther King. The arc of history is long, but it bends towards justice. And I think that's why we're all here now, to try and keep pushing forward. Thank you.
I suspect we are all also here because of UNFPA, not just me, and the things we've seen and, on the ground there. I think, and I was remiss when I introduced you when I said that you were talking about sustainability. It was with regards to supplies, and so I think you've certainly mapped that out a bit for us. I also was remiss when I was referencing Janet's comments. To not talk about how she talked about the broader approach to dealing with sexual assault and gender-based violence. And so now we're going to hear from Danye van der Straten, and she's going to talk to us a bit about her work. She's a legal advisor for Trial, which is Track Impunity Always, and she's going to talk to us a bit about work around accountability issues and conflict-related sexual violence, and talk a bit about some experiences she's had around prevention in Mali.
Thank you. I've got a good news, is that we're getting closer and closer to the wine and cheese. So thank you. It's really an honor to be here and to have the opportunity to share some thoughts with you. Just to present Trial briefly before we start. Trial is a non-profit organization with a mandate to fight impunity for international crimes. So I'm talking about torture, war crimes, crimes against humanity, and forced disappearance. So we've got offices in Geneva, in Sarajevo, in Bosnia, in Kathmandu, in Nepal, and recently we've just opened an office in the DRC in Bukavu. And we've got a team of lawyers, so basically it's an organization of lawyers, and we represent the interest of victims of international crimes and also, of course, of victims of sexual violence, and that before domestic courts and also with regional and international human rights mechanisms. So my topic today is conflict-related sexual violence. So there's no single answer to this issue, which is very complex, and it requires a response both at the prevention and accountability level. I'm going to start by saying a few words about prevention, and especially my experience working with the military. And then I'm going to talk about impunity, which is really my main area of work, and how to address impunity, how to promote accountability, and as well as the interplay between domestic and international justice systems. So throughout history, from Genghis Khan to Hitler, rape and sexual violence has been a feature of most conflict. And we know that it lasts also long after a conflict has ended. We've also, it's also well known, and we've heard it here, that sexual and gender-based violence escalate in times of crisis and displacement. So generally speaking, less is known about gender-based violence prevention than response. And one of the reasons for this is that prevention has received less attention and is not that well understood, is that it's complex and also it's quite difficult to measure. By contrast, if you think about vital, life-saving response services, they are quite easily measurable and very concrete. So you can say, for instance, that you have 50 women that were raped have been treated in your center, and that they have received medical care and emergency contraceptive. On the other side, prevention is, much less tangible. So you cannot say that you have, 15 girls were not raped because of your rule of law program. So of course it's much more difficult. Engaging men and boys is essential in preventing sexual and gender-based violence. So one of the common tactics for engaging males consists of raising awareness about gender-based violence and about the rights that they violate. But this is not the most effective techniques for this type of work. Some research at least indicates that it's much more effective to start with reinforcing effective and good behaviors. For instance, men's model as protector and as providers for their mothers, their sisters, and their daughters. So just to make a parallel, it's a little bit like the star chart system that I use with my children. When they have good behaviors. So I don't know if it's the same for you, but I find that much more effective than sending them on the naughty step. And I'm not saying here that we should treat all men like children. In addition, it's also very important to identify and engage, male role models as spokesmen for this issue. You can have either religious or formal or informal leaders, and this again is a much better approach than just pointing out men as merely perpetrators. Then, engaging state and non-state armed actors is also an important component of any prevention effort. For instance, the military and peacekeeping forces are critical partners, both for prevention and for protection. But the problem is that they're not always very well equipped just to deal with that type of issue, which is very sensitive and difficult. And in addition, the problem that you have is that in certain cases, like for instance in the DRC, they're also one of the main perpetrators. So besides the vetting, another important issue is the extent to which, the code of conduct of military personnel deal with this issue, and whether you have disciplinary procedures in place, and if you do have those, whether they will be appropriately implemented, and if the perpetrators will be appropriately sanctioned. So that's really a key point. So one of the ways to work on prevention is to work and to strengthen the capacity of the armed forces and armed groups. So earlier this year, I was sent to Mali by the British government as part of the European Union training mission in Mali, EUTM Mali. So EUTM Mali is a military mission to which European Union countries contribute military personnel to train the Malian armed force and help them to fight the jihadists in the north. So I'm not a military person, as you can see. I'm a lawyer, and I was the only civilian on the base and one of the few women in Koulikoro, which is 60 kilometers outside of Bamako. And I was working and living on camp with about 400 European and 700 Malian troops. So what was I doing there? So my role was to train the Malian armed forces on human rights, international humanitarian law. And my mandate was really to strengthen the capacity to protect civilians from human rights violation, and especially with a strong focus on sexual and gender-based crimes. So when I came back, a question that I got a lot was, is it really worth it? And does it really have an impact? And my answer to you is yes. As far as I'm aware, out of the 6 battalions that have been trained so far in Koulikoro, none of them have committed human rights violation. And also we used a very basic tool, but just to measure the impact of our training. So what we would do, we would ask the soldiers before we started the training and at the end of the 10 weeks training, the exact same questions. And regarding the treatment of women, I'd like to share 2 quotes with you, which come from the same soldier. So before we started the training, he told us, "Rape is the beauty of war." I'll let you meditate on that one. And after the training, he said, "I will treat every woman with respect like my mother and sisters." And so for me, this says it all, because, training does really have an impact. And of course, yes, it is difficult to measure, but that's not a reason not to do it. And really, each woman who gets raped in conflict, it's a tragedy. And I think if there's just only one woman which did not get raped because of the training that I deliver, I think for me this is a victory. So now that we've talked about prevention, can I have some water?
Of course.
Wait.
Pass it down.
Sorry, you got it yourself.
So now that we've talked about prevention, I'd like to talk also about impunity. So the Rwandan genocide and the war in Bosnia have brought the issue of sexual violence in conflict to the world's attention. And after that, significant steps have been made by the international community to try to address this issue. But despite all those efforts, in most countries, perpetrators of conflict-related sexual violence commit these crimes with total impunity. In terms of consequences, impunity exacerbates conflict and tension, it undermines reconciliation efforts, and it feeds a cycle of violence. So combating impunity is not only about bringing justice for the survivors or the victims, it's really also about international security and stability. So impunity for rape and other forms of sexual violence is complex, and victim faces vast challenges when they're trying to access justice. So I'd just like to mention a few. You've got social issues of stigmatization and ostracism. This is also combined with, in many rural settings, a strong preference for traditional justice mechanisms. Then procedures can be terribly slow, and costly. Judicial personnel will be underpaid and influenced by bribes and corruption. Then you've got problems of access, security, witness protection. All of these are even magnified when we're trying to conduct an investigation in the midst of conflict, and they have a direct impact on your ability to gather evidence. Finally, there's often also limited political will to address impunity, and this is often owing to the fact that perpetrators are state agents. So now that we've discussed some of the challenges, I'd like to talk also about, what can be done to address this and, the minimum framework that you need to have in place. So one of the first things that you need to have is security. So enhancing victim protection is a sine qua non for reporting. Too often, victims, lawyers, justice officials will be subject to threats. So it is essential to ensure the security if you want victims to come forward and if you want judges to be able to press charges despite the threat of retaliation. Then there's this issue of capacity. Successful prosecution requires good investigation. So before you can close the impunity gap, you need to close the capacity gap. And the understanding so far is still very limited amongst justice officials of those type of crime. So just to give you an example of trials work, we've just opened a new office in the Democratic Republic of Congo in South Kivu, in Bukavu. And we are in the process of setting up a new pilot program which specifically aims at training and mentoring human rights defenders and lawyers, specifically on the documentation and investigation of sexual violence crimes. So another problem that you face is that legal and policy frameworks in conflict and post-conflict countries are often inadequate, and they lag behind international norms. So it's very important to continue to advocate for the domestication of the Rome Statute and the development of domestic laws which ensure that rape, which amounts to torture, war crimes, or crimes against humanity, that those crimes are criminalized at the domestic level as international crimes, not just as ordinary crimes. It's very different. That they define consistently with international standards, that they're not subject to prescription or statutory limitations, and that they provide for command responsibility. Another key requirement to close the impunity gap is also proper political will. The International Criminal Court operates on the principle of complementarity, which means that it will only come into play if states cannot prosecute domestically. So because of the mandate, the International Criminal Court and international tribunals can only deal with a very limited number of cases. And usually they will only deal with high-ranking perpetrators. So their work alone is not sufficient to close the impunity gap. It is therefore crucial that states comply with their primary responsibility to investigate and prosecute serious international crimes, including sexual and gender-based crimes. And I'd like to give you some examples of trial strategies to combat impunity. So it's very important that states also implement better their existing international legal obligations. So trial uses and has developed litigation strategies which use universal jurisdiction, and I'm not going to expand on that because I see that I received a 5 minutes warning. And also the use of regional and international human rights mechanisms, such as the UN treaty bodies, the European Court of Human Rights, or the African Commission for Human and People's Rights. So in terms of our work with regional and international human rights mechanism, we use this really to put pressure on domestic authorities so that they adapt the legislation and also to provide justice and reparations for the victim. And I'm just going to tell you a story of one of Trial's clients now. Let's call her Fatima. So Fatima is from Burundi, and she was 9 years old when she was kidnapped by an officer of the Burundian army who was patrolling the area she was living in. And he kidnapped her, took her to his domicile, and raped her. So quite classically, the mother, her mother was abandoned by her husband after she refused an out-of-court settlement. So the mother then brought a criminal complaint on behalf of her daughters, and the instructing magistrate recognized the veracity of the child's account, and a medical expert confirmed also that the child had been sexually assaulted. So far, so good. Then, despite all the evidence, at some point the investigation was just put on hold, and the case was dismissed. So what do you do next? So Burundi has ratified the Convention Against Torture and made a special declaration under Article 22, which means that these facts amount to torture, and it means that we can file an individual communication against the state, and that's basically what Trial did. So last year we took on the cases, and we filed an individual communication with the Committee Against Torture against Burundi, so against the state, not against an individual, alleging a violation of Burundi's obligation under the convention. So this is the first ever case of sexual violence against Burundi that has been brought up before the Committee Against Torture. And if this leads to a condemnation, it means that this child will finally get the justice and recognition that she deserves. And hopefully also it will pave the way for more successful prosecution at the domestic level. And so just one final point. Trial is working with victims of conflict-related sexual violence in various countries. And all the victims, when we talk to them, they always say the same things. What they want is justice. So while prosecutions alone will not bring an end to sexual violence in conflict, there is immense potential to use these legal strategies to deliver justice and also to deter potential perpetrators. So it's really now time to shift the stigma from the survivor to the perpetrator, and also time to shatter the culture of impunity for these crimes and bring those responsible to justice. Thank you.
So I wasn't lying, was I, when I talked about the various ways we were going to talk about these, or ways that we were going to talk about these issues, whether it was through conflict, whether it was through epidemics, whether it was through natural disasters. And as you know, now I really do want to devote the remainder of the time to a dialogue. It isn't just about presentations here. There's a lot of expertise in this room, a lot of programs that you all work on that are addressing these issues in the community as well. And I certainly know, I could kick things off, but I do want to give the audience a chance. But I do know one of my questions when we do get a chance. And Danye really talked a bit about the role of boys and men in these issues, and I know that's a question I want to pose to all of you, especially a man who's working on these issues on the ground, to hear a little bit more about. But before I ask them to address that, I think I do see a question in the back of the room, if we want to start with that one instead. And please introduce yourself and affiliation.
Hello, I'm Barbara Simmons. I'm Dean of International Education at William V.S. Tubman University in Liberia. And what I would like to ask the panelists is, what is their recommendation as far as what we can do as women to address this? We have our organizational approaches, but once I had an internship when I was in law school at UNDP Gender and Development, and I was just amazed at the amount of tension between the female groups. So what can we do as women to address this?
Do we have another question, or we can answer? We have one right up here, and then we'll answer collectively.
Hi, I'm Sarah Papa from the Health Policy Project, and actually I was going to ask about engaging men and boys, but mainly just across all of these really great presentations, kind of a constant that you're seeing is the impact of gender and gender issues underlying all of this. So whether that be traditional gender roles as the women as the caretaker, increasing her risk to Ebola, or the stigma surrounding adolescent use of emergency contraception, or even gender roles of, in emergency settings of women collecting firewood or collecting water and increasing their risk for violence. And also just the basic gender issues that, constrain women from seeking basic health services in non-emergency settings. So how are these exacerbated during these situations? So I was wondering if you could all comment, or any of you comment, on how to address this. And mainly a big way of doing this is engaging men and boys. So if you have, in any of your experiences, come across doing something like this, or if you have, comments on approaches for doing so.
So apparently we all want to talk about gender. So why don't we actually start, and then we'll open up for another round of questions after. But perhaps it's easiest if we just go down the line. Ugo, if you want to get us started. So we have two questions, three, including mine. Two of them specifically are around gender roles and engaging men and boys, and then also what we can do as individual women when it comes to these issues as well. No, it's on.
Okay, thank you very much. Talking about engaging men and boys is like a whole other, but maybe what I'll do is I'll speak about two of the strongest examples I know. And in the case of, interestingly, Liberia and Sierra Leone, and the end of the conflict in both countries, the role women played, and in fact, the Nobel Prize winner, Gobawi is her surname, her first name. Is it Layla? Malala. No, not Malala. Yeah, the film, Pray the Devil Back to Hell, yes. So the role that and it was actually grassroots women's organizations. It started in the church. It was the YWCA in church, and working with the equivalent version in the Muslim community. And it was grassroots women basically saying enough is enough, and engaging men from their role as women. So it wasn't a case of women trying to be men, but it was women as their role as women and the role that they play in culture and society. Engaging the men and saying that enough is enough. We're tired of our children. We don't want to bury any more of our children. We're tired of our daughters being raped. And through a process that took some time, though, they were able to contribute very significantly to the end of the war, both in Liberia and in Sierra Leone. The other example I wanted to speak about is in Niger, and it goes back to the last speaker and the comment about what has been most effective is reinforcing the positive role men and boys can play. So in Niger, we have something called husbands' clubs, where basically you identify champions in the community. And these champions, male champions, form clubs of their peers. And basically through community engagement, they are able to pass on these, would I say pass on? Encourage, advocate for good behaviors. And it's like a snowball effect. And it was found to be so effective that it's actually now a nationally owned intervention by the government. And this is something that started in communities and shows that we actually, let me say this properly. That shows that men and boys can be positive influences on themselves and can actually, I don't want to just say respect the roles of women and girls, but that can be done within a society where typically the gender roles or the power relations are not supportive of that. That within the culture and at the community level, it is possible to address, not necessarily, I don't want to use the term challenge gender norms and stereotypes, but work within the culture to ensure that women and girls, whether it's access to family planning, whether it's decision-making in terms of number of children to have, whether it's being protected from sexual violence or other forms of violence, but that it is possible.
I think I'll start by addressing sort of your comment. So my background is as a nurse. So for my entire career, I've been educated and mentored by women. And I think that has built a foundation of not just interest, but also drive to address these types of issues. And I think my work in Haiti previously, the desire for women to seek health and to create healthy families and healthy living situations was something to me that I felt and feel that you have to continue to engender that and continue to fight for that. And so I think for me, addressing gender-based violence and access to prenatal care and women's health is not an option. I think one of the things that I've noticed in Liberia around Ebola has been the social mobilization, and a lot of the community engagement has been with the women. Been around sort of the trust that we have for women within their communities and women within their families, and that engagement coming from a pretty high level creates a system where there isn't there isn't an option but to follow these social mobilization push and messaging that we're putting out through the women, right? And it's the same for some of the, for example, MSF is doing now in Monrovia some malaria prophylaxis. All of that stuff goes to the women of the household, and it's their responsibility to distribute that. And I think that that empowers the process, right? I don't know if that necessarily addresses the question, but
Yeah, you said there's no option. They got the answer from me.
yeah, yeah.
I would just like to say two quick things. One is just to give an example of a really nice model that I once saw in Darfur that I still think about. I think it was with funding from UNFPA, and it was initiated by a local hospital because there were very high rates of FGM, of female genital mutilation in the area. And I remember going into this hospital and meeting with one of the directors there, and there was this really shy young man sitting in the back. And he was just lovely and sort of quiet, and the director explained, like, oh, well, this quiet, sweet young boy is really revolutionizing FGM in this area. And they had hired him to go from village to village, to give him funding, and to sit down with the village heads, just sort of men to men, and talk about the negative effects of FGM, what some of the consequences were, that it's not indicated in religious texts, that et cetera, et cetera. And that, in that context, it's not something that you can then just use everywhere. But that really worked. It was men talking to other men about this issue. So I think about that sometimes. The other thing is that, and I am guilty of this, is that sometimes in the reproductive health world, we talk about women and girls as though all the needs around reproductive health have to do with women and girls. And when we talk about men and boys, we talk about it as a means to addressing the needs of women and girls rather than addressing the reproductive health needs of men and boys. Men and boys absolutely have reproductive health issues. They're vulnerable to HIV, STIs, their own sexual violence. We see it's not addressed, not brought forward. They also don't want to have They may not want to have children in these settings. They may not want to, they certainly don't want to see their mothers, sisters, or daughters come to harm's way. So I think part of when we think and talk about reproductive health, we also have to bring in men and boys for their own right to health.
Actually, your comments made me think of two things this week. For those of you who follow our blog, New Security Beat, I think it was just yesterday, and my colleague Sky can correct me if I'm wrong, was International Men's Day. And so we had a blog post about that, which talked about some of what you're saying, addressing men and boys' needs around sexual and reproductive health in their own right. The other thing is, I know a handful of you in the room here, as well as probably a bunch watching online, probably tuned in earlier this week when we had UNFPA's State of the World Population Report launch. And we had two young men on the panel. And one of the things, I have to say, that was by far probably one of my favorite events. I can't rank them. Who am I kidding? They're all amazing because the people who think about them. I'm just kidding. But the thing, both of these young men brought up maternal health and reproductive health in conflict, independent of this event happening this week, and that really I found that particularly moving. And it was I would encourage you if you have the time to we archive all of our events online. You can watch it at any time. Take a look at it. Shortly we will have an event summary that'll speak to that effect as well. But definitely, if you are interested in the role of men and boys in this context, you can hear about these two young men's experiences. That was particularly moving. So Janet, I know that some of your images, and her PowerPoint is online, so if folks want to see some of those images, I think we didn't have a good angle, but it was probably clearer out there. But I did see some men, especially there was some young men, nurse, if I'm not mistaken, in some of your images. If you could talk about the work that you do with men, and then also as individual women.
Yeah, sure. One thing that I would just like to tell a story, I guess, at Tomping, POC, there was a man who was a village chief that came up to the reproductive health officer one day and said, it looks like you're seeing a lot of women taking care of a lot of, health issues here. And I just want to tell you that if you ever need me to call a meeting to talk to men or to talk to anybody in the community here in the POC, about any problems that you're having in making sure that care is available for, the women that are coming to this clinic, I'm available. I'm very happy to hold any meeting, that you would like me to have. We want to support you and to make sure that the services are available. So I don't really have the follow-on to that, but I know she did have a meeting and all of that. But I think just to highlight that there are lots of, not to use the buzzword, but champions, and they are, that among men, boys, women and girls, everybody, to really kind of keep promoting equitable access to services for, everyone. And also we had a adolescent-friendly services meeting in Western South Sudan a few months ago. And it was really interesting there. We had both, boys and girl youth there, as well as a lot of other stakeholders represented. And we had been wringing our hands about how are we going to start talking about adolescent sexual reproductive health. This seems like it's going to be a big problem. And everybody just started talking. I mean, we hardly had to say anything. And we just really used the entry point of, we just want, we want to talk about adolescent health today. And then before we knew it, the state medical officer was saying, I've really been wanting to have these conversations. I don't even know how to talk to my kids, but I know that I need to. So I really appreciate having, an opportunity to talk about these things. And maybe one last thing, just to say that I think, lots of different organizations have done a lot of really interesting, innovative work. But I saw some really great work that CARE did in terms of really raising awareness and starting with, if you're running a program, starting with your own staff and really getting in touch with your own attitudes and perceptions. And then before you start working in communities so that you're comfortable having those conversations that everybody else is talking about.
Yeah, communication is huge, which everyone is alluded to, including men in the conversation. Another NGO that I'm familiar with, ARC, they did participatory video programs. In Liberia it started, and the first video the community made was "Do Not Rape." And it showed a man raping a young girl. And then 2 years into the program, they'd made 40 videos, and one of the latter videos was a man can be a rooster, or a woman can be a rooster. And so that showed a man who took care of the house and the woman who went out and ran the little shop. And then he was getting ridiculed by his friends, and he's like, it's okay, a woman can be a rooster too. So it just shows you, and these are videos that the community made, so when men and women start talking about it, they identify the huge issue first, rape, and then they start talking more and more about gender roles and what's acceptable. So starting the conversation, I think, is a huge thing. And I think about the story that you said about the man who raped the 9-year-old girl, and what did that boy see in his life that made him think that was okay? Like, how much violence had he seen in his life to make so if we're not talking at the onset with both boys and girls, then we're really missing the picture, because it's 50% of us. Yeah.
And Dunya, perhaps you can take the other side to this, since you're the one who had us all thinking about this, I think. I know that you work with survivors, but what is the work that you do with women that haven't experienced it as well? Do you work with them in communities, whether it's around education, or what does your organization do in that realm?
Actually not, because we're lawyers, but so we work with other organizations who provide that kind of community support, but we really just one part of a bigger response that is given. But just to go back to the engagement of men and boys, so we've got one man on the panel. I'd like to know how many men we have in the audience.
It's not too bad, actually.
But again, so yeah, I think it's not many, and I just wanted to say that from my experience working on
Tuning in online.
on sexual violence, the problem is that very often it's still seen as a woman's issue, and and people coming to these events are mainly women, and I think it's so important to have male sponsor, and for instance, William Hague, who launched Sexual Prevention, Sexual Violence in Conflict initiative, was a great champion and sponsor for this cause. And I think he was such a great sponsor because also he was a man. I was working on I was on the expert working group, which was working with this initiative to develop a new international protocol on how to document and investigate those crimes. And for all the meetings, there were probably 25 women and 1 man in the room. And I think this is really a problem and this needs to change. Yeah.
I see a question in the front here, and then there's 3 diagonally, and we'll grab those 3.
Hi, my name is Diana Arango, and I work for the Global Women's Institute. Hi, Hugo. I used to also run the GBVIMS for UNFPA a long, long time ago. But now I work for the Global Women's Institute, and I just finished with World Bank colleagues a systematic review of interventions that work to prevent and reduce violence against women and girls. And much like what Hugo said at the end of her presentation regarding the effectiveness of changing norms and attitudes around burial to curb Ebola transmission, we found that community-based interventions that included both men, women, girls, and boys were the most effective types of interventions to reduce violence against women. So I was just wondering, Hugo and Janet, if UNFPA and IMC has considered these types of community-based mobilizations as part of their emergency response to gender-based violence and changing some attitudes around reproductive health.
Thank you. My name is Matthew Julasik. I'm a professor of architecture at the University of Colorado at Boulder, but I'm spending a year at USAID in the new Global Development Lab doing something that I'm completely unqualified to work on, which is talk about scaling up new technologies and how that's achieved, particularly using systems dynamics as an approach. My question, however, is about my research and any impressions or research that you might be familiar with. I'm trying to figure out how we can make more humane IDP camps. It seems to be a de facto response, and clearly gender-based violence is a big part of the way camps are now, and I'm hoping, as an architect, to figure out ways to design refugee camps that, in the short term, would help prevent gender-based violence, and I'm wondering if you have any examples in your experience where that might be a topic that's come up. One last thing, Uga and John, I have a question specifically about Ebola that I'd like to take offline. So before you leave, I'd like to speak with you. Thank you.
We can talk about that over wine and cheese downstairs. I want to build on your last question there, where you talked about more humane camps that would help around gender-based, that could help address gender-based violence. And I'll ask the panel when you answer that to also think about what can be done at camps to help address maternal health needs as well.
Hi, my name is Bergen Cooper. I'm a researcher with the Center for Health and Gender Equity. This conversation has been really rich and engaging, and I particularly appreciate hearing so much about EC. I'm wondering what happens to women and girls who are raped in conflict and do become pregnant. What are the referral systems for abortion services? How are these women getting abortions if they need and want them? Thank you.
And I'm actually going to turn around and ask you a question too, because I do know that Change is doing some work around that. And if you could share with the audience some of the work you're doing as well, that'd be great.
Change is doing a campaign for 16 days called Break Barriers, and we are asking the administration to address HELMS and to ensure that women and girls who are raped in conflict do have access to abortion services. On December 9th, we'll be having a rally in front of the White House, and if anybody would like to get more information, please come and see me afterwards. Thank you.
At the wine and cheese reception. I'm just reminding you all in case you forgot. So I do know there were some questions that were broader to the, I guess maybe we'll go down the panel again, Ugo, if you don't mind. Going first again, I know there were questions about how UNFPA and IMC in particular work around community attitudes, and then around camps, how we can design them differently, and then around providing services to women raped in conflict, women and girls raped in conflict.
Okay, let me start off with emergency response. So, engaging men and boys, certainly for UNFPA, is a fundamental strategy. The thing with emergency response is that it's very, very context specific. So the way you would respond, not the way we would, the way we responded in Typhoon Haiyan in the Philippines is okay, don't let me say completely different. There's an essential core, but on something like engaging men and boys, the way we do it in South Sudan is very different from the way we did it in the Philippines. And we typically have to go through whatever is the social system or structure in that particular context. So whether it's you have traditional leaders, or very often it's religious leaders, but at the community level. So it is, for lack of a better term, part of the standard package, but the extent to which we're able to do it is a factor of what the context is on the ground. So for instance, in the Philippines, for Typhoon Sendong, we had basically, so you identify, I mean, the term is a local champion, you know, somebody that exhibits, you know, a positive, is a positive role model and is able to engage his peers. And then we basically organize them in little groups, and we separate men, women, and adolescents. So it's the discussions are close to that particular group. And the challenge with it is you typically need to do it in small groups and at the almost like the smallest unit at the community level. So the challenge more for us is how do we do it at scale? How do we ensure that we're able to cover all of the men and boys as well as the women and girls who are affected in that particular disaster? Far more difficult to do in South Sudan, where you have a security situation and most of the population are not in camps. If they're in camps, so for instance, in Jordan, let's say, for example, we can do much more than what we've been able to do, for instance, in South Sudan. But the short answer is yes, it's a fundamental strategy for engagement, particularly in the context of addressing and promoting positive, not just positive gender roles, but also within that particular culture. So another example, we were able to get, basically by sending religious leaders in the Philippines to Egypt, we actually got a fatwa supportive of family planning. So this was actually men saying that women should have access to this. Very quickly, on the question of humane IDP camps, I don't know if you're familiar with the SPHERE standards, which is, I mean, what is supposed to be the minimum standard for an IDP camp. I think the only place in the world where we have actually achieved SPHERE might be in Jordan. Even in the Philippines, when we tried to push for SPHERE standards for camps, the SPHERE standards are higher than the living conditions of the affected people before the disaster. So it then becomes really difficult to advocate for SPHERE in a disaster when they didn't have that beforehand. So what the focus has been, and which is why the picture about the latrines with the doors is with the locks on the doors and the segregation is so important, is that to make it humane and safe is not rocket science. There's simple things you can do to significantly reduce the risks to the affected population, particularly with regard to where you locate these things, having lighting, having it segregated, having locks on doors. These are not expensive things. Similarly, with how you locate reproductive health services, more in the center as opposed to on the exterior, I think of the camp. But the biggest challenge has been that with most disasters, your affected population is not in the camp. They're in a host community, and you have to work with whatever is available within that host community and the services that are available. And then on the question of rape, so I can speak of two different contexts. I can speak of Nepal and I can speak of Philippines. Nepal, abortion is legal. So it is not difficult at all to ensure that a survivor of sexual violence who requires an abortion can have access to an abortion. In the Philippines, abortion is not legal. So there is no official way that we can ensure that a survivor of sexual violence who's seeking an abortion, that we can officially provide that to that survivor. And even in the Philippines, emergency contraception is not legal either. So there's no, and certainly nothing I would say on the microphone. There's no way to officially provide that, which is why the advocacy, which is why prevention is so important, as well as access to family planning, and as much as possible, prioritizing prevention of sexual violence right from the start of the emergency, not waiting for 3, 4, 5, 10 women to be raped to then say, okay, we need to put something in place.
I think for the most part, I should defer to the rest of the experts. But it's interesting when you ask about humane IDP camps, because one of the things we talk about in providing Ebola care is how can we do that in a humane way, because it's very difficult to spend a lot of time in the unit. There's something that goes against who you are at your core as a healthcare provider to reach a certain point on the clock that says if you stay in longer, you're putting yourself at risk. And so you turn around and leave people in a terrible state. But also to bring it back to maternal health, one of the things that we've been working hard to address is how to humanely care for pregnant women and laboring women within the Ebola treatment unit. And that has been the provision of safe delivery kits, and having a private space, as well as adjusting your staffing so that there's someone there to attend to that woman and her baby as much as possible. So interesting parallels there, but not your question, so we'll move along.
But good points, thank you.
Just in regards to the humane camps, the UC Berkeley has a sexual violence program there, and they came out with a study, I think it was 2013. It was a multi-country study across a number of IDP and refugee camps that looked at what are the best models to prevent and minimize sexual violence. Also, within a camp setting, how can you care for a survivor of sexual violence, ensure their safety within that camp, particularly if the perpetrator is from that camp. So I'd really encourage you to look at their work. Also a fantastic group. Then in regards to safe abortion, this is a huge issue. It is a major, major gap in humanitarian settings. In fact, IWOG just came out with, they're about to publish a 2-year global evaluation. So from 2002 to 2004, IWOG did a global evaluation on reproductive health and emergencies, and now it's just wrapping up at 2012 to 2014. Safe abortion is one of the primary gaps that we are finding. Not surprisingly, it just sort of confirms what we've already known. And this is safe abortion to the extent of the law. So certainly many places you can't provide safe abortion because it's not legally indicated, but even to the extent of the law, it's just not being provided in many settings. In other places, there are some fantastic NGOs that do provide it anyway, because they're awesome and they're doing the right thing, in my personal opinion, even though it is illegal, and probably many of you know who those might be. So it is happening under the radar, but we really need to it's just not talked about enough. It's a sensitive issue, but to the extent of the law, we're not even talking about national change. To the extent of the law, humanitarian health actors need to make sure that this is available. It's a life-saving service. Obviously, I feel very strongly about it.
Okay, so community-based interventions to address gender-based violence. I know we are doing quite a few things. And taking kind of this multi-sectoral approach, for example, in DRC, we were really working a lot with the communities to improve their willingness to accept survivors of sexual violence back into their homes after they've been cared for and treated, and so and using the case management approach also has allowed for this multi-sectoral response to the survivor, and also to be able to speak with immediate family members. And there's a socioeconomic component, that's very critical, and we've also been working on that quite a bit. Because, of course, if somebody has economic independence as well, that also gives them more power and more ability to be able to be integrated back into the community. There's protection clubs that are oftentimes used in different settings where you can engage those who have power in the camp or have power in the community, and then they can work with women and those that are at risk to ensure that they have the escorts that they need to be able to go to the latrines at night, or to be able to go to showers, or to be able to walk around in the community. Solar lights are something very simple, but that's not so much a community-based approach. But in addition to all these other kinds of, I just want to mention that's one that has really allowed women to feel safer. And
deliver at night, probably too.
Yeah, that too. So let's see. Then, in terms of what was the other question? Sorry, access to abortion. It is. I don't think I have much more to add to what the others have said. The one thing, maybe, as Melissa was talking about emergency contraception, we could do much more to make that available. Because, what I see many times is that people think of that as only for somebody who comes in for treatment for rape, when it should be available for anybody who needs it, for whatever reason it is. And so there could be a lot more work to talk to communities and educate them about how it's used, as well as providers, and again, working on provider attitudes. I think that's all I have to add.
Yeah, I mean, just quickly, I've never worked in a country besides this one where abortion is legal. And I've worked in a lot of countries, but I've never worked in a country where I didn't talk to the women about what they did when they wanted to get rid of a pregnancy. So there's all sorts of ways. One of the most interesting was in northern Uganda, using tea bags, like 2 packets, like the big boxes of tea bags. And they told me if a teenager or a schoolgirl gets caught with tea bags in her backpack, boom, she's immediately ousted of the school. I'm like, really? They're like, yeah. So, I mean, there's things that exist. And I just think, I know CARE and other agencies here, including you guys, post-abortion care services are legal. When that happens, getting that woman to the clinic to make sure that it's safe. If it's stimulated by some local method or way, is really critical, I think, to women's health. And the other thing is, I came from this other meeting with Michelle Maloney-Kitts, and I just say that because she runs the Together for Girls program at USAID, and one of the things she said this morning, if there was one fact I could tell everyone in the whole world, I would say 72 hours. 72 hours after you have you're raped, you need to access EC and post-exposure prophylaxis, and you're safe. And I thought that was really powerful to distill it down to one fact, 72 hours. And again, I think it's just showing that we're underutilizing EC in a lot of these settings for that reason.
So I think a lot has been said already. Just one thing I wanted to add about the abortion question is that even in countries where it's illegal, of course, some organization will still try to do it. But my understanding is also that, and I don't know if you've heard about that, but that in some countries, even if it's legal, some NGOs who will have some US funding, for instance, will not do it because otherwise they will not get their funding. So I think that's also a very important point to make.
Yes, I think that there's quite a few of us that know a lot about the global gag rule that you're referring to. Did you want to add anything?
Yeah, just one last thing, because obviously this is something we all feel very passionate about, but I'm reminded of two things. One is a discussion I had when I recently moved to the Philippines, and there were all are supportive, but there were some who felt that we need to move the term reproductive health out of the appeal for emergency support, that it was attracting too much opposition from various groups, and for the sake of the larger appeal, remove the term reproductive health. And this is from colleagues that I work with very closely and I know are very supportive of reproductive health. And I thought, how can my first assignment as the new rep be not to use reproductive health, even though I understood where they were coming from. And then someone working for a grassroots organization said, Ugo, we have negotiated the term reproductive health. We have fought for this thing. It means so much to us. And that we now have a space for reproductive health. Let's protect that space. Needless to say, we kept reproductive health in. We dealt with whatever the opposition was. But I think the point I want to make with regard to abortion is, we always, certainly for the UN agencies, we always have to be very, very respectful of the international resolutions or treaties that create the space for us to do the work that we do. And yes, oftentimes there's a lot of personal conflict in that, but we're very strongly mandated by what the national law in the country is, and if we don't work within that, it could erode the space that we have been able to get to. We can now talk about reproductive rights. We couldn't talk about reproductive rights not so long ago. So it's a passionate battle. It's a long battle, but success comes in incremental steps, and it's great when we're all like-minded and passionate about it, but oftentimes the people that we have to engage with so that we can reach those that are affected are not in the same space we are. So, okay, let me just stop there. If not, I'll just keep on going.
So I do want to be conscious of the time, and I usually take a moment now to thank you all for joining in the discussion and encourage you to continue having these dialogues, whether it's following our website, our blog, Facebook, or Twitter. And then I ask you all to thank me in joining our speakers, which of course I do want to ask you all to do that. But I also do want to acknowledge a comment that John said earlier, and that was that he's going back to Liberia next week. So I also want to take a moment to thank you for going back, going to begin with, but to going back. You are the second male panelist we've had in the last few months. For those of you who come to our dialogues, Ranu Dillon, who spoke in July on nutrition and the continuum of care from preconception to postnatal care is in Guinea. So we've had two amazing men on our panels recently who are out there doing work on the ground around Ebola and maternal health. So thank you, and thank you all for your comments, and thank the Swiss Embassy for enabling us to continue to have this conversation again 2 floors down. You always mingle afterwards. Just mingle downstairs, see the art opening, have your follow-up questions with the speakers all downstairs, and have some wine and cheese while you're at it too. Thank you.
Did you see that email from Jessica? She's going to